this is the distribution for 50, 40, and 20%. So 80% is the stated goal. Certainly, this is a aspirational goal that we are all excited to hear about. The reality is that these are the numbers of patients starting or with a ESRD diagnosis in recent years. We all know that the total number of patients has been going up, and the vast majority of those patients, about 89%, start with in-center hemodialysis. PD is down here, and then the percentage of patients with the preemptive transplant is here. Home hemo was not depicted in this particular slide, but the bottom line is that we have a lot of room for improvement to achieve the aspirational goal that was given to us. I think I'm talking mainly to individuals who are very familiar with dialysis, either as patients or as care providers. We all know that the choice of a replacement therapy is a very complicated, emotionally charged for patients and their families. The most common decision typically is between in-center hemodialysis and PD, although very clearly other options exist, like transplantation if you're able to get a preemptive transplant, home hemo, as well as not doing dialysis, but going on a conservative management therapy. It's a difficult decision, and we know that patients often do not feel well informed or supported. You might have heard there's been a lot of talk about shared decision making, which is in the medical field usually is when there is equipoise between two treatment or two therapies, and it requires a collaborative approach between the clinical team, the patient, and the family. The typical steps are the patient and the clinical team review the medical evidence and the details about the two different treatments or multiple different treatments. There needs to be a intent and time spent soliciting the patient preferences and the values and what are the things that are important to the patient, and then address potential outcomes. Now, having said that that is the ideal decision-making process, I would like to poll you asking, for patients deciding to start peritoneal or hemodialysis based on their preferences, improves which of the following? And you can select all that apply. Again, I'm giving you a little time. So I think that a consensus is there. We all, or most of you, think that they're all important, and especially that might have an impact on their quality of life. Oh, I apologize. I was not sharing that. So all three. It's absolutely true. There is actually a lot of evidence that shared decision making results in increased knowledge on the part of the patient, and also helps patients identify what their needs and their wishes are. The decision that they make has relates better to their needs, and then once they start treatment or implementation of that care, the care aligns with the patient's preferences. That in turn results into increased compliance. For example, in our case, patients really being compliant with the dialysis prescription, and ultimately that also results into better clinical outcomes, for example, lower hospitalization rates. While this is obviously important, I think that the sense of empowerment and the sense of participation in their own care that patients experience, in my mind, is the most important outcome per se. Obviously, this is a process that poses challenges. And I'm sure for many of you, top of mind is the time to sit down and to have that conversation really is more time consuming. There are also issues around how complicated the medical lingo can be. Sometimes there are complicated numbers or formulas, and so we as clinical teams need to do a better job in helping patients understand or providing information in a more understandable manner. One other issue is that, especially for frailer patients, those with multiple chronic conditions, the older patients, sometimes families and loved ones out of care want to make those decisions, and those not necessarily align with the patient's wishes. And so we need to be very careful. While it's super important to include patients and caregivers in the decision making, ultimately, whenever the person is able to make that decision, it is the person with the specific disease that we are dealing with who should make that. And then ultimately, I think really this resonates with me. We were not trained as medical professionals to implement shared decision making. And so my interest in this was really a personal one, and I can say that through this project, I was able to learn a lot. So we probably all have our own biases and perspective of what the patient's perceptions are. As part of this PCORI-funded study, we actually asked patients on hemo and PD a number of questions that related to their experience at the time they started dialysis. So in this example, we said, which of the following happened when you started whatever the dialysis modality is? And in the case of, and these are in-center hemodialysis patients, 66% said, I was told I had a choice, but more than a third said, I was told it was the only choice for me. Now, this might be a case for a very, very small proportion of patients overall, but it is unlikely that that is actually accurate. On the converse, patients who ended up choosing PD felt that they were much more empowered and were really given a choice at the time that were considered dialysis modalities. When we ask patients, do you feel that the decision to go on whatever dialysis modalities they went on was largely your choice? For patients, I think what's most troubling is that among hemodialysis patients, 47% said that no, they didn't feel that that was their choice. And this is an example of a quote that a patient who ended up going on hemo said, my kidney doctor just walked in and said it. And this was a really sobering message to me as a physician, because I do think that even though we all strive not to give that impression, this is what that specific individual recalled. And so this is definitely problematic. What we all would want is the experience of this one patient who started PD and said it was 100% my choice. They explained the differences in the modality, and PD just made more sense to me. So this is what we are striving for. And I think that at least our data, and there is a lot of literature supporting the notion that patients do not feel currently empowered in their decision making. So I'm curious, for the next poll, in your experience, how is education about choosing between peritoneal dialysis and hemodialysis usually conducted? And there are several educational tools listed here. Please select all that apply for you. So typically, we know there are brochures, there are in-person classes. Education takes place before coming to the dialysis center. Online decision aids, recommended patient talk to other patients, recommend patients do research on the internet, and none of the above. So the most common themes seem to be using brochures, the classes, and then often the education happening before dialysis. So we, as either clinical staff in the unit or patients might not really be aware of what happened prior to dialysis start. I think this is really aligned with what we know, and that's why we were excited to develop a decision aid that would be useful for patients with advanced CKD starting dialysis. So what are decision aids? They are tools, and they can be either web-based or paper-based that present some basic information about the health condition. They help individuals recognize that they need to make a treatment decision. And then they help patients identify risk and benefits associated with whatever modalities or treatments they're considering. Help them clarify what are the things that are important to them, so what is called a value clarification exercise. And also often they provide the experience of other patients. So it's fairly straightforward. I was really surprised of how much work and effort goes into developing one of these. We were very fortunate to receive funding by PCORI that supported this study, and there were several steps that went into it. First of all, as you might know, PCORI really mandates that there is a collaboration between more traditional researchers like myself and patients, caregivers. This is the mom of a child who has had kidney failure since infancy, as well as other members of the care team. These are social workers. It's been an amazing experience for me as a researcher, as a clinician, and as a person to really open up to the opportunity of learning and collaborating in doing research with people who traditionally are not part of the research team. So having said this, one of the factors that we wanted to look at was what are the things that are truly important to patients, because we wanted to be able to incorporate those in our decision aid. And so for our next poll, what do you think is the most important factor for people with kidney disease when they're considering treatment options? I feel like there is a pretty clear winner here, which is quality of life and maintaining independence. I would say that I'm pleasantly surprised because at least until a few years ago, I think longevity and staying alive as long as possible would have been considered the most important thing, or at least the perception that clinical teams had. The most important thing was to prolong the life of their patients. And clearly now we are shifting towards recognizing that quality of life is the most important factor. So we actually went through the exercise of asking patients, both patients with advanced chronic kidney disease as well as patients who had started dialysis, what were the factors that were most important to them. And in alignment with what you just shared, keeping independence, quality as well as quantity of life, flexibility in daily schedules were the three top. And obviously, this will also differ a lot for different patients. So, for example, when we looked at the younger patients, keeping independence or ability to go to school or to work were far more important for example, participants who were 45 years or younger compared to other age groups. But overall, these were the factors that patients identified as most important. We then asked a subgroup of patients who had already started dialysis, how did dialysis impact your ability to do all of these things? Because again, we wanted to be able to provide the patient perspective on the impact of the two main choices that we were presenting within our decision aid. And truly, the perception of patients was not that different between PD and hemo on all of these factors. The one thing that PD patients felt strongly they were better able to do after starting their own treatment was relying on myself And that's not surprising given that they are providing their own care, and that likely results in them feeling more empowered and more participant, as well as more flexibility in eating the food I like and drinking as much water as I like. So we use these results. So what patients told us, what the patients and the clinical team on our research team gave us to develop a web-based decision aid. The decision to have it web-based was largely driven by our desire to reach out to the largest number of patients possible. One of the feedback that we did receive was that more and more patients have access to the internet, and so that was perceived as an appropriate format. We really tried to have a streamlined website. There is this navigation bar up top that kind of goes through the decision-making process, from what do the kidneys do in health, what happens to the kidneys or once the kidneys stop to work, why do you need to make a decision now, what are the most common types of dialysis, and then we go into the value clarification exercise. So we tried to also have a very streamlined layout and navigation, as well as simple language. Having patients as collaborator was really key because they went through every single word in this website and provided very strong feedback when the perception was that it wouldn't be clear or immediate to the average person in the clinics. We also use pictures and graphics, which there is scientific evidence and studies supporting the notion that it really helps adult learning. And one thing that I'm also really excited about is that there is a page that is dedicated to care partners, family members, loved ones. I think that we all know the chronic kidney disease is a very pervasive condition that has an impact on everybody in a family. And so I thought it was really important to provide that perspective for family members. Now, one thing that I do want to state up front is that this decision aid focuses on what are currently the two most common types of dialysis. So in-center hemodialysis and peritoneal dialysis. We absolutely recognize that home hemo, transplantation, and conservative management are all additional viable and very, very important treatment options. Based on the funding that we had, the time that we had, we chose to prioritize the two types of dialysis that currently cover 95% plus of patients starting renal replacement therapy. And so having focused on these two, as we compare, as we provide more details on how each of those treatment options happen, we then try to really clearly summarize in a table how, for example, in terms of how does it change everyday life, how does hemodialysis compare to peritoneal dialysis? And again, here's where patients were really instrumental in coming up with the impact that the different treatment modalities had on their own life. We were very lucky to have a range of patients who had really been exposed to anything from transplantation to home hemo to PD. So we hope that this is a concise and clear comparison that is helpful to patients and their families. We then go into what most patients really found really excited, and it's what I referred to earlier as helping patients understand what their values and preferences are. So based on what patients told us in those interviews, based on the literature, based on what we knew from our own experience within our team, we came up with a series of values or things that are usually important to people and then to specifically individuals who develop kidney failure. And those are listed here. And the patient, these are, I apologize, it wouldn't be possible to do it like a live demonstration, but you can literally go to this website. And these are sliding bars where a patient goes in and say, okay, having someone else in charge of doing my dialysis, it matters a lot to me or it doesn't matter at all. Seeing my healthcare team more often. And so they can slide for each of these options, like a slide left or right. And this is an example of this patient. Based on their decision or based on the preferences that they indicate here, the height of these bars go up and down. And ultimately, based on these responses for patient A, it seems like PD might be a better fit for them. Conversely, for patient B, based on, again, different responses, in-center hemo seems to be a better fit. Now, I want to be very, very clear. These results are not mandate and do not in any way indicate what is the right modality for that patient. This is meant as an exercise to help patients think through those factors and kind of provide their own perspective and then being able to share it with their care teams. Obviously, clinical factors, feasibility factors, a number of other factors go into this decision. So this is just one additional aspect that we want to be able to collect and to have information as we are working with patients making this choice. As I mentioned, our patients were really, really involved, so much so that we ended up having literally hundreds of tips from either the patient or the social workers on our team that were very concrete. Things like PD supplies can take up a lot of space, but here is how we can help. You can think of organizing them, things like that. One of the things that I really like is the suggestion of printing out the results from this exercise. And there is a print button on that page so that patients can maybe use this as a tool to have a conversation with their care team when they're having, because it would be easy for patients to kind of forget or not consider all of these factors. And so we are hoping that this can be useful to them. So this being a scientific study, the ultimate way that we test whether something works or not is to do a randomized controlled trial, which means you randomly assign some patients to the standard of care, which right now includes in-person classes, brochures, all the CKD education that we were referring to earlier. And then other patients are randomly assigned to the intervention. And in this case, the intervention is going through the EPOC decision aid. So we did both in-person recruitment at CKD clinics in Michigan. We also did a national outreach via social media in collaboration with the NKF and the AAKP. Ultimately, we were able to get 234 patients who agreed to participate in the study. 116 went through the standard of care, and 118 went through the decision aid. Now, we asked patients, both in the control and intervention arm, to answer questions and surveys before and after the study. And so the last to follow up, these are individuals who did not complete the study for some reason. Either they were missing a survey or we were unable to reach back to them. So one of the questions that we asked participants in the study was, which type of dialysis do you think you might choose when you need to start dialysis treatment? And in the next couple of slides, I have the same layout here. The control are the patients who received the standard of care, and we're always comparing them to the post-TET. So the patients who did go through the decision aid and their responses after they went through the decision aid. So you see a big difference and a big jump. After going through the decision aid, about 16% of patients said that they would choose in-center hemodialysis, and the percentage of patients who said they would start on PD also went up. I thought it was also, sorry, I apologize. The percentage said they were not sure decreased dramatically, and the percentage who said they would go on PD also increased. Now, as we anticipate, not everybody would choose to go on PD. Many also said they would be interested in in-center hemodialysis. And overall, the use of the decision aid resulted in having at least a better sense of what might be a good fit in terms of dialysis modality compared to patients who didn't use the decision aid. And this study actually was just published last month. So if you are interested in more details, that's in AJKD. There are some specific measures of things that are important when you are trying to improve a person's ability to make a decision. One is the so-called concept of decisional conflict, which means how comfortable are you to make a certain decision, in this case, the choice between those two dialysis therapy. And there are scientific scales to measure those constructs. And this one that's called decisional conflict was significantly lower in the patients who use the decision aid after they use it compared to prior to the decision aid. We also measured the knowledge around kidney, TKD, and dialysis modalities. And the level of knowledge was greater for patients who used the decision aid versus those in the control arm. Finally, perhaps most interesting to me, these are the opinions that patients expressed after going through the decision aid. When we ask how much did the decision aid influence which type of dialysis you would be leaning towards, you can see the distribution here, but quite a bit or extremely is highlighted here. How helpful was the decision aid to you in understanding dialysis options? Again, overwhelmingly, they said it was quite a bit or extremely useful. And how helpful was the decision aid in understanding kidney disease? Again, the patient's perception was that it was quite helpful. So in summary, we show that the choice of dialysis modality is obviously a very difficult experience. Currently, under the current model of practice, the patient's needs are not being met, or at least the perception of patients is that they're really not participating in a shared decision-making process. I think it's fair to say that clinical teams need to get better at listening, communicating, and eliciting questions. This is not at all a criticism of our clinical teams out there or of my own nephrology colleagues. It's just a reality that we were not trained, and the current system, with the limited time that we have to spend with patients, certainly doesn't align or doesn't support shared decision making. I think that we need to be creative and think what are additional or new tools that we can use to increase that. And decision aids might be one of the tools that we want to consider. In our study, the EPOCH decision aid really performed well, was well accepted by patients, and it had an impact on the metrics that we looked at, specifically knowledge around dialysis and decisional conflict, so how comfortable patients felt in making that decision. Again, as we stated earlier, an improved understanding of what the patient's needs and perspectives are may result in an improved fit between each patient and then the dialysis modality that best fits his or her own lifestyle. Obviously, there has been a lot of emphasis on home dialysis, and I'm a huge proponent of such. Clearly, if you compare the rates of home dialysis in the United States compared to the rest of the world, we have a lot of room for improvement. I think we also need to recognize that for some patients, in-center hemo might be the best fit. We had a patient who expressed how for her, going to dialysis Monday, Wednesday, Friday was like going to church on a Sunday, where for her, that was her social environment. So I think as clinicians, we need to step back and not put our own biases and expectations on a patient or what that patient's needs are, but really listen to what their preferences are. Realizing that most patients do not feel comfortable or empowered in expressing those preferences. And so an instrument like the decision aid can help them clarify those values for themselves and then hopefully share those values with their care team. One thing that I was really excited to, one more polling question. Have you used a tool to make or help someone else make a decision about starting PD or hemodialysis? And I am actually curious about this, so I'm going to give you a few extra seconds. Okay, this is definitely interesting to me. It's about a 50-50 split. In my own clinical experience, tools like this decision aid are not broadly available in clinics. So I would definitely be interested in learning more about what's out there and what other tools are we referring to. Because again, I think we are trying to put together a toolbox where we leverage different tools for different patients or perhaps multiple tools for the same patient, because it's well demonstrated that we need multi-touch education to promote adult learning. So for at least for our adult patients, to truly have complete information about such a complex decision, it is unlikely that one class or one session or one pamphlet will be enough. And so I envision tools like the decision aid as one additional tool to put into our toolbox. To me, this is probably the most important slide of my whole presentation. As I mentioned, I felt very fortunate to receive funding during the first round of PCORI funding for this specific study. As an agency, PCORI has always been very, very clear that they mandate that we share results of the research with the broader community. And obviously, the work that May and others are doing is a testament exactly to that. So after the study was completed, so for the past year, the decision aid that I just demonstrated has been publicly available. Anybody can go to this website, www.choosingdialysis.org. And I would encourage, if you have the opportunity to do so, please reach out if you have feedback. And my hope is that you can find an application for it, whether you are a person who has kidney disease or you have somebody who is a loved one who has kidney disease. And even more so, because I assume that most people on this call are actually healthcare professionals, consider if you see an opportunity to implement this decision aid in your own practice. I would like to leave you with this picture, which is, again, a testament to what PCORI mandated. In this picture, there are 4 people who were quote-unquote professional researchers, and then everybody else is either a patient or a caregiver. We have social workers. It's been a really exciting journey. I think we have generated a better product, in this case, a better decision aid, because of this collaborative approach. I actually just reached out to each of these ladies and gentlemen last night about this presentation, and they were very excited that I had the opportunity to present to you. So again, I hope that this can be helpful. I actually think I did really well on time, if I would say so myself. So let's see what kind of questions you guys have. Okay, one question was how to get caregivers involved. And I assume we mean family members or loved ones. I agree that that can be tricky, although in my experience, I don't want to say the majority, but a high proportion of our patients do have family or loved ones they rely on. And so asking patients, being proactive and asking them to come in with their loved one, or if we see them in the waiting room, reaching out to the wife or the son. I think that's really important. We also need to acknowledge that not everybody will have that. And so that sense of isolation can be actually even worse for patients who do not have a strong social support outside. So I think that's also something to be very mindful of. Switching to a different modality. What to do if patients change their minds after several months and they want to switch? As we know, that occurs, and it occurs quite often. What we really try to stress in the decision aid is that this is a decision that is important you make now because you have a clinical need, and is not a decision that you're making forever. You will be able to go back and reconsider, and in fact, we have tips throughout where we try to support the patient if they feel that a certain dialysis modality doesn't align with their needs anymore, to give them tools to go back to their care team and have that conversation. Now, before we go into more questions and answers, I wonder if I should be looking a little bit at this chat. I don't know that there are specific questions. Thank you for enjoying the presentation. And I see that we are already giving you some answers. So going back to more questions here. Can you further clarify the optimal time to use the decision aid? This is a really good question. We developed it thinking of patients with stages 4 through 5, CKD stages 4 to 5. Realistically, it's unlikely that we're even aware for the majority of our patients that they will need dialysis so early on during the process. We are all familiar with the so-called crashers and patients who didn't even know they had a problem with their kidney or even what kidneys were until very recently, or maybe the week before they start dialysis. So ideally, the earlier on, the better, although I shouldn't say the earlier. I would not have the conversation about dialysis modality and even bring up a decision aid as an option until realistically that is in the somewhat immediate future. So again, probably stage 5 or so. I think we also need to be very clear that with the patient that this is what we anticipate to happen based on the trajectory of your kidney function. We obviously don't have a magic wand. We don't know exactly when this will happen. In my mind, though, the earlier is better because it gives the patient and the family more time to digest something as complex as dialysis. Is there anything being done to help nephrologists move patients to transplant before they ever get to dialysis? In my mind, the executive order is huge in this regard because they really are stressing the importance of preemptive transplantation. As I showed earlier, the current numbers are so small of patients receiving a preemptive transplant is so small that they hardly showed on the graphic that I showed you earlier. I think awareness and the policy perspective is a huge driver of awareness, is a great way to look at that. Obviously, the issue is organ availability and whether a person has a living donor who is a good match. So I think, again, education is for both patients and providers and families and the general public around organ donation is huge in trying to increase preemptive transplant. How can I assist a patient who is on the fence about switching to PD? She's hesitant about getting the surgery. Well, first of all, try and share this decision aid and see if that helps her. I assume you're talking about a specific individual, clarify some of her questions, seeing the answers that I'm sure she's already has received multiple times, framed under a little bit of a different lens. The other part that I am really passionate about, and I wish Nikki, who is this lady right here, was able to contribute, is what is referred to sometimes as peer mentoring, which means having a patient who has gone through the same experience, so in that case, a patient who is ideally currently on PD, so has gone through the PD insertion and then the training, talk to the person who is making the decision. There is, I think, nothing more powerful than sharing the understanding with somebody who has gone through that same experience. And so I have found that facilitating interaction with other patients who have had similar experience is usually very effective. Let's see, this last one is, I like the idea of a decision tool. In our home program, there were patients who rushed or pressured into home hemo or PD who, even with training, were not emotionally prepared to deal with conducting dialysis. I think this is a huge issue. As I mentioned, I think we're all very enthusiastic about home. More broadly, the community is becoming more supportive, and policy has also and is being implemented to push on home more. There is absolutely no doubt in my mind that we need to increase the number of patients who dialyze at home. At the same time, we also need to recognize that home is intense. And the person who asked this question, I think the emotional toll that treatment can have on the patient and their families sometimes tends to be discounted from the clinical perspective, because we think that absolutely this is such a great opportunity for this person. he or she will be able to do the things that she enjoys the most. She gets it or he gets it. He will be able to train and do the treatment very easily. So I would encourage all of us to work with patients in making this decision, so being honest on what doing dialysis at home requires. None of the barriers is insurmountable. In fact, I had one colleague one time telling me the only reason why a person cannot do dialysis at home is if they don't have a home. And even in that case, there are cities that are working around how do we provide care for a homeless population. So I don't think that there are insurmountable obstacles, but we should be aware of what those obstacles might be for a specific individual. In my experience, supplies and the weight of the boxes can become particularly problematic for an older person who is on PD and either suddenly loses their support system or are just deteriorating within their choice. So I suppose I took a little bit of a long time to say, let's be honest, and in my mind, let's try to give the answers that we would give to our loved ones. So there are definitely pros and cons between these two choices, and let's try to present it to them, and let's try to really help patients be mindful about what are the things that are important to them. I think I have actually addressed all of the questions that came up here.
Francisca, there's one more question from the chat box, if I think we have time to answer it. And they ask, how do you get the nephrologist to allow the CKD patients to be seen early or prior to starting treatment?
I'm very intrigued and interested in the phrasing of this question. In my own clinical experience and thinking of my colleagues, I don't think there is ever a reticence or resistance to referring patients to CKD education early. And I would be interested in knowing what the rationale for that are. In my mind, the main point is that we are not even aware that a patient has a CKD, because obviously being asymptomatic, that's sometimes just a random finding on labs. In the case of patients that are followed in a CKD clinic, I would agree that we don't want to refer them or even ask them to consider a dialysis modality when their GFR is 80, because likely they have many, many years of slow decline, and they're probably never going to progress to dialysis. That's where I think you don't want to do it too early, and maybe the resistance on the part of nephrologists might be if we are referring to CKD stages 2 or 3, but I in my opinion, most clinicians will be supportive. I think that the barrier so far has been that we don't really have the resources and the tools. We can sometimes refer to an educational class. We have some pamphlets. So the hope by providing additional tools like this one is that we can be more creative and provide education through quote-unquote non-traditional channels compared to what we've done earlier. And hopefully that will also help alleviate the nephrologist's concern that they can't refer everybody to that one class that is made available. Did you have any other comments, or does anybody on the line have other comments or questions?
Francisca, I think you did a wonderful job answering all of the questions. And I just wanted to thank you again for this very important webinar. I hope everyone that's on the webinar will go to the website and explore this tool for yourselves and use it, of course. We only have a few minutes left, so I want to let everyone know that when you exit this webinar, you need to click on a continue button to take you to the evaluation form. And then to receive your CE credit and also to provide us with some valuable information for conducting future webinars, we ask you to please complete the short evaluation form. And to give us better insight, we've designed separate survey questions for patients versus questions for ESRD staff. So please, thank you again for completing that webinar right now, and we'll be in touch with you about future webinars. And again, thank you so much for attending.
Thank you all. Please go
to
choosingdialysis.org.